I'm Ben. I'm a clinical and health psychologist. I work between the MARTA in psycho-oncology and the John Hunter in liaison psychiatry. And I'm talking today generally about the psychological aspects of having some sort of brain cancer. And what I'd like to do, if that's all right, is just talk in kind of general terms and hopefully give you some rules of thumb. So some of this stuff will, not new to you, and that's fair enough. Just treat it as a bit of a refresher, but hopefully there's something a little bit useful in there. So I guess what I'm getting at is it's more on the rules of thumb, practical stuff you can do, end of things, or rules of thumb for understanding as opposed to very theoretical. Is that all right? Great, thanks. All right. So the first thing I'd like to talk about, and probably the most common thing that we see in psycho-oncology, is distress. Now the thing about distress is it is a type of stress, okay? And it's worth noting that because stress in itself isn't a bad thing. So what this graph is showing that people's performance is affected by stress. But if you think about it, a little bit of stress, which is good stress or what we call eustress, actually increases your performance. So this is like just before exams, I would suddenly get really good at studying, right? But before that, when I wasn't very stressed about the exam coming, my study technique wasn't brilliant. Does that make sense? So you start off and you're not very stressed, but your performance isn't so high. But as you get more stressed, your performance gets better. But there is a point where that peaks and starts going downhill again, and that's where we're talking about distress. So if we're speaking to someone, and if you're, as a patient or as a carer, seeing either the patient or the carer becoming stressed, the thing to think about is this starting to affect their performance? Are they, when I say performance, I just mean functioning. Is it getting in the way of their daily life? Because then it's probably what we would call distress. But if it's just stress and it's actually spurring them on to be more organised or, more open or whatever other things that are important to the two of you, then it's probably not a bad thing and definitely worth encouraging and normalising. So when I say normalising, just saying, hey, that's pretty normal that you're stressed about this and you're doing really well with it. Does that make sense? Okay, so not all stress is distress and not all stress is bad. The next most common thing that we would get a referral for is depression. So I like kayaking, and I don't know if you can see, but right down in the bottom here is a little kayaker, dwarfed by the huge mountains, and it's dark and fairly lonely looking. That's what a lot of people describe depression feels like. So diagnosing depression in cancer is a reasonably contentious thing. It's a tricky thing. The reason being is a lot of people think the worse the illness, the more likely you're going to be depressed. But when we're talking about clinical depression, we know that's not the case. So yes, cancer patients and indeed brain cancer patients have higher rates of depression. But it's not in any way aligned with the severity of the illness. Interestingly, that's also the case for carers of brain cancer patients. They have higher rates of depression or indeed all mental illness than the general population, but they actually have higher rates of mental illness than the cancer patients themselves. Does that make sense? Yeah. So because of those two facts, what we generally use in a psycho-oncology service is a susceptibility stress model. All that means is someone is likely to end up with some form of mental illness if they're already susceptible, so they have either some genetic predisposition or just stuff going on in their life that makes them more susceptible, and then the massive stress of the diagnosis and treatment. And you can see why the massive stress acting on someone who's already susceptible also happens to the carer. Right? It's pretty stressful for carers too. So that's the way we look at it. It's not that cancer directly causes depression or any other mental illness, but the stress of the situation does. And that's why you don't actually have to have the cancer yourself. But if you're in that situation, you are more likely to have a mental illness or a depression. So, the rule of thumb. As I said, diagnosing depression in cancer is tricky, and it's a big argument. It's been going on for about 35 years now, and it's not settled. So don't believe anyone who says there's a definite way. But a rule of thumb, I think, for you guys is to look at it this way. It's inappropriate sadness. Okay? So if you go to a funeral and everyone's crying, do they have depression? No. Why not? It is sad, yeah. If you wake up in the morning and you're sad to wake up, and you're sad about your Weet-Bix, and you're sad to look out the window, and you're sad to get dressed, and you're sad to leave the house, is that appropriate? Not usually, unless you particularly hate Weet-Bix. It's not a particularly sad thing, is it? So that would be what we call an inappropriate sadness. And that's what we're looking for when we're looking for depression or a clinical major depression. Does that make sense? So that's something to look out for in yourselves, but also in the people you care about, either as a patient or a carer. All right. Anxiety. What's anxiety? Any ideas?
Heart palpitations, sweaty, shaking, feeling a bit numb.
Okay.
Running to the hospital thinking you're going to die.
Okay, so heart palpitations, sweaty, leg a bit numb. Anything else? You want to go to the hospital because you think you're going to die. Yep. So that's probably what we would call a panic attack, all right, which is the extreme end, and that's when your body reacts to anxiety. That's when your body is getting into what we call fight or flight. And all of those things are related to fight or flight. So heart palpitations, if you're going to fight for your life, you need more blood, and so your heart starts pumping faster. You start breathing more to oxygenate that blood, right? So you breathe faster, your heart goes quicker. You get hot because you've got hot blood going into all your muscles. You get a shot of adrenaline, so you get that kind of shaky feeling. What else? Digestion shuts down because that doesn't help you fight. So that's the extreme end of anxiety, and that's panic. Oh, and then you notice all those things and think this is something seriously wrong, and you think you're going to die. So anxiety is a little bit before that, before you get to a full panic attack. Anxiety is basically worry, right? It's just worry. And worry is just thoughts, okay? That's all it is, it's just thinking. Do you know what a thought is? How would you define a thought? It is on your mind, yep. It does worry you often. All right, so thoughts in our world, because we want to name everything, we call thoughts the internal experience that has language, okay? As opposed to an emotion, which is more like a colour or something. An emotion is something you feel, and you can kind of talk about, but you can't really name. Thoughts, on the other hand, have words, and they have language. So if you have words in your head that are a worry, it's a thought, and it's a particular type of thought. It's a self-protective thought. It's a thought that says, hey, watch out. So you can see that worry, and therefore anxiety, is a really natural, normal thing because it keeps us safe. So, if you think about cavemen running around many years ago, and some of them have the thought, or the self-protective thought, or the worry, hey, there might be a bear in that cave, I'm not going to go in there. Some of them wouldn't have that thought. They go in the cave, and eventually there would be a bear or something in that cave that kills them. And they all die out. Or the caveman who thinks, these berries, they could be poisonous, maybe I shouldn't eat them. Watch out. It's a self-protective thought. All the ones that don't have that self-protective thought eat the berries, eventually will come across poisonous berries and will die. So the only ones that are left are the warriors. So all of us, all our ancestors were the neurotics, if you want to put it that way, in terms of cavemen. Okay? So it's a natural, normal thing, and it keeps us safe. It's a system that stops us walking out in traffic because we have the self-protective thought or the worry, hey, there might be a car coming. Okay? So anxiety itself doesn't worry us as psychologists. We think anxiety is normal and good on you for having it. What we're concerned about is what we call an anxiety disorder, meaning disordered anxiety, disordered worries. So it's really useful to have the thought there might be a car coming, look both ways. But if you can never cross a road because you're worried about cars, then that's become disordered anxiety, disordered worry, disordered thoughts. Does that make sense? So what we're looking for, the rule of thumb for anxiety is not, are you worried? Now, if you or someone you care about has cancer, worries are pretty normal and natural, right? Your mind is trained to give you warnings and, hey, watch out for this, watch out for that. So, of course, it's going to say occasionally, hey, watch out for cancer. Or some version of that, right? That's a really normal thing to have. The problem comes when that worry gets in the way of stuff, when you can't cross the road, when you can't turn up to the hospital, or you can't answer the phone, or you can't speak to people, or you can't play with your kids or your grandkids, or it gets in the way of living. That's when it becomes disordered, okay? So the rule of thumb for you is not, am I having worries? Because I can tell you you're going to have worries. It's, are these worries getting in the way of something, getting in the way of stuff? Fair enough? So anxiety disorders, they get in the way of stuff. Okay. Positivity. I speak to a lot of people about positivity. A lot of people are concerned they're not being positive enough. And in fact, that's probably the biggest problem with positivity and negativity is it's a common thing out there. People will say that to you. People say, stay positive. You might see it on TV. Lots of people put that message forward. It's often spruiked by deregistered TV psychologists who talk about positivity all the time and the power of it. There is some power in being positive, a bit. But there's a problem with it. When you've actually got something going on in your life that isn't particularly positive, right, like cancer, there's going to be bits of that are negatives. And if you go into that thinking, I have to be positive about everything, otherwise my health might suffer, you're setting yourself up for failure, because I just said we're entirely involved to have self-protective thoughts. We're entirely evolved to have worries, which are, by nature, negative, right? So the idea that you can be positive about everything and therefore never have negative thoughts is unrealistic, and no one ever lives up to that. Then if you attach something, as severe as your health or even survival to never having negative thoughts, which I just said is impossible, you can get really upset and get really worried that, hey, I'm having these negative thoughts. Is this going to affect me in some way? So there's sort of two bits to this one. The first one is you can't be positive about everything, okay? And that's unrealistic, against evolution and nature, and just not how our heads work. At the same time, it is useful to be positive in a global sense, in a general sense, about your life. Because the opposite of that, being negative in a global sense, that's depression. We don't want that. That's that inappropriate sadness we're talking about, right? So when you think about positivity, and in particular positivity in context of you or someone you care about having cancer, the idea is look out for global positivity. Just are they generally positive about life in general? Because you don't want to be negative about everything, that's problematic. But definitely not do you have to find the bright side of someone cutting you off in traffic, or stubbing your toe, or being scared about the results of a scan or a blood test. Okay? Of course your mind's going to generate those worries. Does that make sense? Yeah. Does that ring true for people? 3 of you. Excellent. All right. Another thing that is quite difficult in a cancer context is the idea of information. So, like I said, there are some inherently negative things about going through cancer treatment. There are some scary things, and a lot of those are unknown. And they're unknown by you, but they're also unknown by the medical team. You just don't know yet. You're waiting for results, you're waiting to see what happens. And that makes us, as humans, uncomfortable. We're going to have lots and lots of self-protective thoughts going, hey, what's going to happen? I hope it works out okay. Watch out for this. When we're uncomfortable, a lot of the time what we try and do is get away from that discomfort. And one way that people try and get away from discomfort is, I'm going to try and solve that uncertainty, right? And so they ask for more information, or they search for more information. They get on Google and they spend, they don't go to bed until 4 a.m. reading stuff, reading more and more and more. And ultimately what we know is, if that's the way you try and solve that discomfort, if that's the way you try and solve that uncertainty, once again, you're setting yourself up for failure, because what you really want to know is what's going to happen to me. You really want to know what's going to happen in my situation. And that is unknown. There is no website that explains that. There is no textbook or specialist that you can, reach over email that will eventually answer that yet. And that's why we know that, one of the most reported things that all cancer patients say is, I would like more information. There's been so many trials, a lot of them run out of Uni of Newcastle actually, where they try and provide more information in different ways, brochures or DVDs or podcasts, all these different sorts of things. And yet people always say, yeah, that was really good, but I'd like more information. And this is my argument, it's because all of that information, however good it is and however well presented it is, it doesn't actually answer that question of what's going to happen, because no one can. So what you need to do, if you find yourself kind of on this never-ending hunt for more information, and it's hard to do, and it's probably easier if your partner does it than you, recognise it and just talk about, hey, is there going to be an answer to what is it we really want to know, and is there going to be an answer to it? And if there's not, then what we're talking about is uncertainty that's just inherent in a cancer diagnosis. And what you have to do then really is go for a level of acceptance. Okay? So that all sounds probably familiar to you, but a lot of people have funny ideas about acceptance. Acceptance doesn't mean liking it, right? Lots of people say, I just haven't accepted it. And when you talk to them, what they mean is, I still hate this. It's fine to hate the uncertainty. It's fine to hate anything, really. But you can really struggle with the uncertainty. You can hate the situation you're in. That doesn't mean you haven't accepted it. Accepting it means I'm stopping myself from trying to remove it all the time. Does that make sense? So acceptance in this case would be, okay, there isn't any more information to find out at this point. I'm going to have to just wait. And I can hate that I have to wait. And I can tell everyone I hate it. And, that could be the carer or the patient who has that feeling of uncertainty and that discomfort from it. The acceptance is just going, okay, I'm not going to do any more about trying to remove it. Does that make sense? Excellent. More people that time. All right. Coping. So it's kind of a general term that people don't think about much until someone gets sick. So this kid has his head stuck in a chair. Is he coping?
I wouldn't be.
You and me. Do you think he is?
It's all right.
He looks alright. He's got a lollipop. He's probably the most relaxed person in that photo, I'd say. Okay. So the psychological definition of coping is dealing effectively with a difficult situation. So there's two bits to that. Okay. First off, dealing effectively doesn't mean dealing well. Definitely doesn't mean dealing optimally, or even how I used to deal with it. It just means effectively. Effective just means, does it work? Okay? So if, on a low level, it might mean getting takeaway on the way home rather than cooking your usual 3-course meal, right? It's still effective. Everyone gets fed. It's effective. It may not be your best, but that's okay. That's dealing effectively. The second bit is with a difficult situation, right? So if you're not finding the situation difficult, you're not coping with it. You're just living. It's just something you did, right? So most of us had sandwiches. If you didn't find going and picking up the sandwiches difficult, you didn't have to cope with getting the sandwiches. You just got sandwiches. Does that make sense? So dealing effectively with a difficult situation means, if everyone's here, everyone's been fed, most people are washed, you all got pants on, you've probably coped today. Does that make sense? Don't judge yourself as not coping just because things are getting harder and you're not doing as well as you would like or as well as you used to. It's not a helpful judgment, and it will also more likely get in the way of your ability to deal effectively because you're all caught up in how terrible you're doing. You're better off just thinking, okay, what do I need to do to get through this? Deal effectively. Just get it done. Okay? That's coping. All right. So when someone has a cancer in their brain, there are often effects on their brain, cognitive effects. So it's a little bit up in the air. It's somewhere between 40 and 80%, which I know is a ridiculously huge range, but it depends on what you read. So we can say up to 80% of people with a brain tumour do suffer some measurable cognitive effect. What they are and how much they bother you kind of depends on your situation. So some people can score just as well on an IQ test as they ever did, but their personality changes so much that they're quite difficult to live with. So personality changes can include things like irritability, so just getting cranky quicker, disinhibition, so doing stuff that you never would normally, or potentially another way of looking at that is inhibition being the little voice that says, Ben, don't do that, right? Which I have often. If I didn't have that little voice, I'd be doing a lot more stuff that I probably shouldn't. But it can also include things like inability to plan, poorer memory, changes in attention and concentration. So I've got that at the bottom as a separate thing. The reason being is that's the one that most people notice. And the important thing about that is that also can happen to the carer. Okay? So attention and concentration is a really brain energy, mental energy hungry process. It takes a lot of energy. So if you're distracted, you're tired and you're emotionally worn out, you're going to be less good at paying attention to stuff. People don't usually notice that, but what they do notice is, I can't remember where I put my keys, or I don't know why I walked into this room, or I went to the shops and forgot all the stuff I was meant to buy. It's that short-term memory stuff. And they worry, has my memory gone? Right? Now, if you've had some sort of brain tumour, your first thought is going to be, this is because of the tumour. If you're a carer, often the first thought is, oh my God, am I now getting dementia, right? Either way, usually it's neither. Usually it's just that you're worn out and you didn't pay attention. So the thing about memory is everyone is aware of recall as a process of memory. Can you drag up that memory? Where did I put my keys? The thing is, there's more than that. There's more processes to it. And one of the most important ones is the encoding, the putting the memory in. So if I don't pay any attention to where I put my keys, there's no memory to retrieve. So I can have a perfectly working memory, but I paid no attention because I'm distracted, because I'm tired, because I have bigger things to worry about, that I don't remember where I put my keys because it's not there. I don't remember what I was going to this room for or what I was going to the shops. Huh?
I used to use car, not keys.
Yeah. And everyone does that, right? Yeah. And it's, yeah. So it's often more that. It's distraction from attention and concentration, which is a common thing under any sort of distress. Remember at the beginning? So your performance in intention drops because you're distressed. Okay. Then there are emotional changes. So one of the things, like I said, you can be more irritable. That's usually a small bit of what we call more labile, meaning that your emotions flick quicker. You change around faster. Suddenly you're crying, suddenly you're laughing, suddenly you're cranky. You can have a big rush of love for someone. Okay, that's a common thing when you've had some sort of brain injury. But also, there's that sort of functional element of emotional changes, but there are other changes which come from facing a life-threatening illness. And that makes some things seem more important. It makes some relationships suddenly seem deeper or more important because you're suddenly paying attention to things. You're thinking, how important these people are to me and I would hate to lose them. So it's a much deeper connection to emotion, and that means most people get more emotional. And in a similar way, it can lead to a whole reprioritising of your life, meaning what is important to me, who is important to me, how do I want to spend my time? And once again, this happens for the carers too. All right, so there's personality changes, there's cognitive changes, and in particular attention and concentration, which can affect memory. And then there's emotional changes both on the way your brain functions, as in you're faster with your emotions, but also you will find you're more emotional just because you're thinking about big life stuff, which is more emotional. Right? Okay. So, in summary, not all stress is distressing. Depression is inappropriate sadness. Anxiety disorder has to have some sort of impact on your functioning. Is it getting in the way of stuff? Positivity is only good in a global sense. You don't have to be positive about everything. Look out for that kind of constant drive for more information, and acceptance is the answer to that. If you're doing stuff, you're coping. If you're doing what needs to be done, dealing effectively, you're coping. And there are cognitive changes which are normal. I didn't say all of them, the answer for cognitive changes, all of them is purely management of those. So you can come speak to us if you would like a hand with any of those things. Obviously you can contact us through people you already know, any clinician really, or you can email me there. And that's all. Thank you.